On behalf of the New York University School of Global Public Health, I want to wish you all a good afternoon and thank you for joining us for this webinar. My name is Jo Buford and I'm the clinical professor of global health here at the School of Global Public Health. I'm honored to be your moderator today. I want to mention two logistical things before we get started with the webinar. One is the event is being recorded, and secondly, there will be a Q&A period after the panel presentations, and I encourage you to enter your questions into the Q&A box on your Zoom connection, and we'll come back to them later on. This afternoon is a special focus on the impact of the global pandemic here in New York City. And New York City, as we know, was the really the early epicenter of the pandemic in the United States and has taken dramatic action to bring down the incidence and reduce the threat, and is still being very vigilant. But New York City is also a global city, and so we want to really share our experience and look at it in the context of both global health and national health. You're also going to hear from the faculty of the NYU School of Global Public Health, who'll share their research and their engagement with policymakers and program leaders to bring them the evidence they need for action on the challenges of the pandemic. Just a little bit of scene setting. First of all, we learned this morning that the US has reported a record 500,000 new cases of COVID in the last week. And this is now occurring across the US with similar surges that we're seeing in Europe, and accompanying measures to try to constrain the spread of the virus and to deal with the challenges of the healthcare delivery system. As we move here in the United States towards a national election on November 3rd next week, COVID is the #1 issue on the minds of voters, and really people are listening for information and making decisions about their political choices on that basis. In addition to the epidemic, and to some degree because of it, there is also the economic and social consequences that are also being managed quite differently in different countries and certainly in different states around the United States. And we also have the important movements to address structural racism in this country, and also global efforts to look at the issue of colonialization in global health itself. It's important as we move forward to learn from the COVID-19 experience so far, and it clearly is not over, to inform our future preparations for pandemics, but to also address many of the glaring and often quite long-standing problems that have been brought into the spotlight because of COVID. And I think for the first time in many instances, the broader public and political leadership are beginning to appreciate changes that may have been apparent to people working in public health and in public policy for some time. Just to touch on those briefly, first, obviously, are the profound health disparities in poorer communities and communities of color that have increased their susceptibility to COVID and the disproportionate severity of illness and loss of life. Second, we really have begun to appreciate in the United States the need for greater cooperation within what has been a very competitive healthcare delivery system to try and create a capacity to surge to meet emergencies, but also to have attention to the financing systems that have been really encouraging this competition and often discouraging or undermining access to care. Third is a focus on cities. Cities are often ideologically linked to one party or another. This happens around the world, and we have not really, I think until now, often looked carefully at the unique both challenges and opportunities in cities, but they have certainly brought greater attention to the broader determinants of health beyond healthcare, those conditions in communities, especially in cities, that create or in many ways undermine the potential for individual health. Issues like crowded housing, the quality of water and sanitation, the availability of green space, availability of food, even availability in this country and in this state of broadband communications, and issues of environment and climate change. All of these are being looked at as areas that we've had the evidence for some time and the proof of effectiveness of many interventions, but have really not had the public will or the political will to act. And so one of the questions for this next hour and a half or seminar is, will the insights from COVID really open the door to action on many of these areas? And what's the correct role, the proper role, or most effective role for public health and other health professionals in joining with others to really try to get sustained systems change that can promote greater health and health equity. So let me move to the panel who are going to take on some of these challenges, and we know will prompt a lively discussion afterwards. Michael Merson, who's Research Professor of Global Health, Jose Pagan, who's Chair of the Department of Public Health Policy and Management, Robin Gershon, Clinical Professor of Epidemiology, and Jack Caravanos, Clinical Professor of Environmental Public Health Sciences. So I'm going to begin with Dr. Merson, who's a global expert in infectious disease and has been fighting pandemics and epidemics for much of his career. He's going to give us a real up-to-date report on the current global and regional landscape of COVID as a context for looking at the current situation in the United States and in New York, and perhaps indicate what we might learn from countries who've managed this pandemic more successfully that might be applicable as we go forward. Michael?
So in my time, I'm going, as Professor Buford said, present a summary of the status of the pandemic, factors that have contributed to a successful response, and give you a few thoughts on the future. Here is I'll start with this graph, which is the figure which shows you the number of cases and deaths in the world so far. Clearly, we are still on an increase in cases, 43 million about now. Note that it took only 15 days to go from 35 to 40 million. It took 38 days to go from 5 to 10 million, showing how fast the pandemic is still going. I was on a call this morning with WHO, and they informed the world that there has been more, that last week there were more than 2 million confirmed cases, and it was the shortest time ever for such an exponential increase since the pandemic began. So in a nutshell, we are probably right now at a day when the pandemic is as bad as it's ever been, with all the intention that it's still going to get worse. The next slide breaks this down now by WHO region. On the left, you have the region, and there's a color code and the number here of cases. And just to go over this very quickly, if you start at the very bottom with the red color, you see that there was way out in February, you get that China blip in Wuhan, and then you see very little red in terms of cases compared to other regions, because the Western Pacific region, including China, New Zealand, Australia, Japan, South Korea, Singapore, are examples of countries that have handled this pandemic very well. You go up to the top of this graph, in yellow, you will see the Americas. Half of those cases are in the US, half are in Latin America. US has the highest number of cases in the world. In Latin America, we have the most cases in Brazil, Peru, Colombia, Mexico, Argentina, and Chile, with Brazil having the third number of cases in the world. The green color you will see is Europe. And we know that Europe initially had a big curve back earlier in May, in June, in northern Italy, Spain, Russia, which has the fourth highest number of cases, in the UK. But if you look at the green now, you see you get that sense of a second wave. And indeed, I learned on the call this morning that just about all the countries in Europe are now facing a second wave. In Belgium, they doubled the need for ICU beds in one day. Health systems are overwhelmed. More and more countries are turning to partial or total lockdowns. And I'll talk about the US in a second, but clearly the Northern Hemisphere, which is the US and Europe, are really in for quite a winter. In Southeast Asia, which is in purple, you see there is a peak and it's coming down, and most of that is India. I learned on the call this morning that India has half the number of cases it had a few months ago, and they don't know why. There has been a suggestion of herd immunity in a few areas from so many people being infected, but we really don't know. In the Middle East, you see there in green, and that's mostly been Iran and the Gulf states. The Africa in blue is really interesting because we don't really understand why Africa hasn't had more of a severe outbreak. It's been bad in South Africa. That's the only country that's really suffered. Africa has had a severe indirect impact in that a number of its other health programs have slowed down because of the fear of COVID. Theories on why Africa has not been severely hit include the young age group of the population. They had some severe lockdowns followed by some strong community responses. Whatever the reasons, it's good news. The next slide shows the regional overview in terms of deaths. I have the next slide. And next slide back, sorry. And here you can see that 75% of the deaths have been in the Americas. You see the yellow color predominating. There's been a decline in the US and in Europe over July and August, but we now are expecting and starting to see a rise as the pandemic spreads in that second wave across the Northern Hemisphere. Overall, there's been a decline in case fatality, and that's because more young people have been infected. We're better at treating the disease, and we're doing more testing, although that's not playing near the role that you might hear on your television set. For example, in the last few weeks, we've had a 23% increase in cases in this country, but only a 2% increase in testing. Next slide. The next slide now, I just want to show you the situation in the US. And this is cases and deaths. And you can see here that we're up now to about, we've had 9 million total cases, 70 to 80,000 daily cases. We've had 230,000 deaths, about 700 daily deaths. But what's really important to look at on the top curve, which Tony Fauci talks about all the time, is the US never got below 25 to 30,000 cases. So some people say we're now starting a third wave. Some people say we're still in our first wave, but you can see here that we have had 3 waves, whatever you want to call it. With deaths, we had quite a bit of deaths in the first phase, but less so now for the reason I already explained. The next slide shows you what's happening by the same graph of cases by geographic region. So in April, we had the hotspots in New York, as Joe mentioned, in Florida, in Louisiana, Detroit. Then in July, we started to see it in other parts of the South, much heavier in Florida, Texas. And then you see in October, we started to see much more in the way of cases in the Midwest. And if I can have the next slide, you will see that if this is last week, the red shows you the high case areas, and the red is rural. So what we're seeing now in this country, clearly, first is much more disease in rural areas. Secondly, a spread now to the mountain areas that haven't had much in the way of cases, the Mountain West and the north central part of the country. North Dakota probably right now has the highest rate per population of cases. And what most people think and are concerned about is that this wave, in contrary to all the other waves, will be national, and it won't be just in 1 or 2 regions of the country. Next slide. And I thought you'd be interested to see this, which is a map showing how different regions of the country have responded to opening up. I mean, the US response has been dismal in many ways, but what I want to show you here is the interesting correlation right now between those parts of the country that have opened up early and now being most severely affected. We'll probably come back to that later. Next slide is another very important characteristic of the response of the epidemic and the pandemic in the US, which Joe, you've mentioned, which is that Black, Latino, Indigenous, and Pacific Islander populations all have considerably higher mortality rates compared to whites. Again, as you said, revealing the great disparities in health status and health care in these population groups. Unemployment rates in this country coming out of the pandemic are also highest in African Americans. So that's a quick overview of where we are. Now let me just show you a slide on what has been, next slide, on what has been the characteristic of those countries which have been successful. And these have mostly been in the Western Pacific area and in Asia. Australia gets mentioned a lot, South Korea, which has 50 million people, Vietnam, which has close to 100 million people. It's not just small countries. And these characteristics are leadership, strong leadership, planning at national level, acting quickly, trust in government, and very important, clear messaging and communications. A belief in science and also in new knowledge, the understanding that when new knowledge comes about, here we had two important examples, one of them being the fact that asymptomatic carriers could transmit the disease, and also when we became aware of the importance of masks. So believing not only in science, but accepting that science can change and the need to incorporate new knowledge in your science. Very important in Asia, experience with SARS, in Africa, experience with Ebola, adequate supplies of PPE, aggressive use and strategic use, I would add, of testing, contact tracing, quarantine, and isolation, adherence when it's needed to mask wearing and social distancing, and again, as I've shown in the last slide, cautious in opening up the economy. These, if you look as a whole of the countries that have been successful, this is how you would probably, I think most people would say, this has been their main characteristics. Next slide. I just want to finish now by talking about the future. I just want to cover 2 points. One is there's a lot of talk about biomedical interventions bringing us out of this pandemic. And there are 3 types that are mentioned: diagnostics, therapeutics, and vaccines. I'm not going to go these in depth, but with diagnostics, we're going to have a rapid antigen test, hopefully, which will be cheaper, easier to use, quicker, and allow diagnosis to be made much easier. Therapeutics, we've got some antivirals now, remdesivir, hopefully we'll have more. We have monoclonal antibody made by Regeneron or Lilly, which looks like it will work early, but not late, and could be given in outpatient settings. And later in the disease, we have dexamethasone. A lot of hype about vaccines. Next slide. And what I simply want to point out here is that there are 10 vaccines in phase 3 trials. There are 6 of them that are part of the Operation Warp Speed. You can see them here. They use 3 different platforms. We understand that the ones using mRNA, the Moderna one and the Pfizer one, are likely to have results by the end of this year and may get emergency use to be used, approval for emergency use. Thank goodness the FDA has fought back against the political process to make this decision early. But we're going to have big challenges with a vaccine, first of all, in delivery. And I want to mention that more than anything. What is this vaccine going to do if it's efficacious? Is it going to just decrease severity? Is it going to prevent transmission? Is it going to give us so-called sterilizing immunity? We don't know, and we don't know how long antibody titers will last. We know that in many people that get infected, they only last 3 months. So we have a lot of concerns about how much the vaccine is going to add immediately to our control of the pandemic. Next slide. Really just reminds us then that for me, we need to remember our main, what we call NPIs, which are our what we call non-pharmaceutical interventions. These are well known. I'm not going to read them off, but they are the ones that, this is taken from Tony Fauci's slide recently that he gave as a talk of the key interventions that we have. And as I've already mentioned, they really work. when they're applied in the right way. And my next slide, two more slides. I just want to finish by saying at a global level, I'm so hopeful that after the election, the US will reestablish its commitment to global health, and where there has been no real success in global health if the US has not participated historically with HIV, with smallpox eradication. We need to cooperate with China. We need to strengthen the World Health Organization, not withdraw from it, and the international health regulations. We need to support the COVAX accelerator, which is helping to get vaccines to low and middle income countries. We need to commit to build back green and with a green and resilient recovery, addressing poverty and inequalities. And we must accept that global solidarity is essential to control the pandemic. And my last slide, Joe, is to set up our next speakers. That's the curve of cases cases in New York. And you see a little bit of a blip. And there's been a blip in Newark I saw this morning. And so I wonder what our future is going to bring us in New York City. Thank you.
Great for opening that question, Mike. And we'll move on now and hear from someone, Dr. Jose Pagan, who's chair of the Department of Public Health Policy and Management, but is also the chairman of the board of the New York City Health and Hospitals, which is really the public hospital system of New York. And he's going to tell us really about the challenges that they've faced in creating and maintaining surge capacity in the healthcare and the hospital system, and recently a new assignment from the Mayor de Blasio, which is to also manage the testing and tracing activity across the city in partnership with the Department of Health. So we know he's going to touch on what makes all that easier and what's made it harder. So Jose, over to you.
Thank you, Joe. Thank you so much. And thank you, Michael, for setting up the sort of like the global context and the city context and the US context with all the challenges that we face. So what I want to do is address three issues that build on what Michael said and that are all connected to the question of what's at stake and the elections in New York and beyond. And actually, my first message before I tell you that is go vote. Lines are long, but take a good jacket and umbrella over the next few days and go vote. So the three issues that I want to talk about are: how did our public healthcare delivery system prepare for COVID-19? What were the challenges that we faced? What are the key elements to that response? And my experience has been more with the public healthcare delivery system, but if you think about it, all these systems had to work together to address COVID. And the impact of COVID-19 has been on minority populations, and low-income populations, and these are the same populations that actually our public healthcare delivery system serves. So the other 2 points is what is New York City doing when it comes to issues such as testing and tracing, working with schools, and how are we preparing for what could come next? And the third point is to build on something that Michael said, which is, it's very hard to respond in the US it's very hard to respond in the US given how segmented healthcare and the public healthcare systems are. I don't know that people realize how segmented it is compared to other countries and disjoint. And that becomes very complicated when it comes to responding to a global problem or to a large problem like COVID. And then when you add another layer to that, which is that lack of consistency messaging from leaders and how to coordinate resources, it becomes really difficult to respond to the pandemic. So let me begin with the first point of impact of COVID-19 and how the healthcare system prepared. Health Affairs, if you want to learn a lot about it, you may want to look at a series of articles that they put together this past summer on New York City and health and hospitals, because it gives you a good overview of what New York went through. But in terms of a background on this, we have the largest municipal public healthcare system in the US. We see about 1 million patients in 11 acute care hospitals, and they range from Elmhurst Hospital and Queens to the oldest hospital in the US, Bellevue Hospital. And you probably have heard of all of them because they have been in the news for the last few months connected to the pandemic. The first confirmed case of COVID-19 in New York City was on March 1st. So we knew right away that given the nature of New York City as an international hub, COVID-19 would have a large impact on us. But what probably no one really knew is the scale of the impact. I always find it fascinating too how people remember dates around that time. They can tell you exactly where they were on the day they were and figures around all of this. So at some point, I was aware of about at least 20 different forecasting models that have been used and taken seriously to track the pandemic and forecast its impact. These are models that are used by Health and Hospitals, the Department of Health, and many others to look at what's going to happen in the future. Um, our public healthcare system, H&H, had experience responding to infectious disease events, HIV, Ebola, but really nothing can prepare you for what we experience with COVID-19. The challenges were many. They range from adding more hospital beds to onboarding nurses and doctors. Think about thousands of nurses and doctors being onboarded, stocking up on protective equipment, and so on. And an important point then is that in many countries, these activities are centralized, but in a federal system like the US, the central government plays a role, then you have the states, then you have localities, and the coordination among them wasn't as seamless as it should be or as seamless as it is in other countries because there's a certain level of autonomy, independence of these local jurisdictions, and that impacts how we're able to respond. Um, it also means that many of these communities, instead of working with each other, they were in a sense competing with each other to get equipment, hire personnel, better coordinate at the national level, and that better coordination at the national level would have made actually a huge impact on our response. So we have, like I said, 11 hospitals. So from March through May of 2020, there were 10,437 COVID-19 patients admitted to our hospitals. More than 2,000 of them were in intensive care units. So the system did everything that they could, canceling elective procedures to increase bed capacity, centralizing the supply chain. We had a phone hotline so that people could call to get an appointment, get tested, do all of that. So as you can imagine, tons of learning took place. And that learning, because of the size of the system, allows us to respond much more rapidly. So I'll mention two key decisions that were made that actually made a difference of how New York City responded to this crisis. The first one, how our public healthcare delivery system responded to the crisis. The first one was that we had an emergency management and incident command system in place. And the second one is that we had a strong analytics group. And I always find it interesting how you come up with an idea based on an experience that you had on something totally unrelated to the crisis you're facing. That's basically why a system like this had a strong analytics group. So before COVID-19, the system has been preparing for infectious disease outbreaks since the Ebola outbreak in 2014. They have collaborated with other systems to develop a national emergency special pathogens training and education center funded by the Department of Health and Human Services and CDC. And that had been critical to the response for Zika, measles, flu outbreaks. And so, there was a lot of experience with infection control, PPE, hospital personnel training. And basically through these resources, it allowed the system to monitor what was going on and respond, despite everything that I said on how complex was to respond in an sort of like a fragmented environment. So a key to our response was, again, that management and incident command center. They communicated, coordinated, collaborated. We had something, for example, a Tiger team. They met once a week. So all the data was presented to every hospital, and we knew where resources needed to be allocated, what were the bottlenecks, what were the problems that different hospitals and clinics in the system were facing in the city. And then the role of analytics, that's the interesting to me, because it meant that we were able to build quickly dashboards that we could use to track what was going on. And interestingly, a lot of that experience was from dealing with chronic disease management and access. So you have all this experience in analytics in one area, and then suddenly you switch it and you're able to provide that capacity to deal with the pandemic. So that infrastructure was the one that was used, and they were very quickly to come up with dashboards to look at COVID admissions, testing, bed capacity, staffing needs, emergency department utilization, and quickly run it through the different hospitals so that they knew exactly what they needed to do, or what were the bottlenecks and problems that they were having. So a lot of the lesson there is a system like that. You always see the bad part of what happened, right? But in a way, you have to also think about the fact that a large system like that rose to the occasion, and it was because and that's why they were able to implement a coordinated, centralized response. And an anecdote on this is like on how quickly you learn. One of the things that we started getting were phone calls from people saying, "I want to help the hospital system, the health system in the city. You guys are, the healthcare, the clinical workers are our heroes, right?" But they didn't know how to, they wanted to know, what do you need? And one of the roles that the board did, which I thought was quite interesting, was sort of like work with the hospital system to say, these are the areas where help is needed. A lot of it was around how do you, when you have doctors and nurses that are working crazy hours and they need a place to rest, they may want a meal delivered to their home, anything that makes them feel better about the work they're doing and appreciate it and all of that. So a lot of those resources, when people would come give us money, went into that. And we had a clear message, that that was any funds that you donate, had a purpose. And we ended up, I think, getting about $20 million through that, just to give you a sense of how that played out. So I'll comment just two other areas very, very quickly. One is contact tracing. The health department has been coordinating with health and hospitals to work on contact tracing for the city. Very important, because when you identify a case, you want to make sure that you're able to follow up on other people that may have had contact with that person, and provide all the resources that they need so that they can isolate themselves. Hotel rooms. I just read yesterday that we even have if you have a pet, we're able to actually help you with your pet, so that if you need somebody to walk your pet and do all of that, we have a partnership with a business to actually do that for you. So it's interesting how much thought goes into it. A lot of what happened on why the health and hospitals got involved in it is its size. They were able to hire many people to do contact tracing. The data in terms of how that's working looks good. And then the other component that I will say is the schools. The city has done on the controlling the epidemic side, quite well in terms of identifying cases, testing, and so on. And the biggest challenge that you hear, for those of you that have kids in the audience, is how difficult it is on the learning side more than on the testing side. So I'll finish with that, and let's keep going. Thank you so much, Joe.
Okay, thanks, Jose. We'll come back to you. I'm sure I already have a couple of questions that are directed right at you. Our next speaker is Robin Gershon, who's clinical professor of epidemiology, and just last week published her findings on new research on the effect of COVID-19 in transit workers. And she's going to give us a little context about the issue of essential workers, which I don't think anybody thought much about beyond the healthcare delivery system until COVID. So Robin, tell us about that and tell us about your work and what it's revealed.
Okay, if we can start with the first slide, please. Thank you. So these are some things that the students in my disaster courses talk a lot about. I'd like to frame the issue of the risk to essential workers in the context of disasters and how they're handled in the US. And they typically have very lengthy and exhaustive commissions that are formed. They take months to write a report. The reports are voluminous, hundreds of pages. And at the end of each of these reports, sadly, the conclusions are almost always the same. And what they say is, across the government, there was a failure. On the next slide, for instance, for the 9/11 Commission, they stated that it was a failure of imagination, politics, capabilities, and management. On the next slide, for the 2005 Hurricane Katrina, they said it was a failure of government officials at all levels, and they failed to provide effective leadership and a coordinated national response. And on the next slide, COVID is unfortunately repeating many of the things that we've learned over the last few decades, plus some more things. For instance, a couple of days ago, I came across a New York Times article by Nick Kristof, and I really love the way he framed it. He said, COVID is a result of the defiance of science. It's put so well, so incredibly well. On the next slide, it wasn't always this way. Really and truly, in the US, we have a very long and wonderful history of having incredible support from the CDC. The CDC, which we refer to in my courses as the mothership, the CDC enjoyed an incredible support worldwide. They were seen and were, and probably still are, the leaders in any kind of pandemic, epidemic, or outbreak. And in the report from the H1N1, they said that prior pandemic planning efforts and federal funding paid off. They said that the Strategic National Stockpile met and exceeded their needs. They did say, however, at that time that we needed a long-term storage plan and a way to resupply that stockpile. They also said that CDC did a great job by maintaining close contact with the international health community, such as WHO and PAHO. They activated their Emergency Operations Center less than a week after the first case was identified in the US, and just a little bit over a month of the first case in Mexico. On the next slide, and during that event, we had over 60 million cases. We had many hospitalizations. We had 12,469 deaths, according to the CDC. Now, of course, H1N1 is a very, very different virus than we're dealing with now. But to make it kind of clear, they developed an effective vaccine in about 7 or 8 months, and they deployed that vaccine. So it's a very different situation. All those plans were in place under Obama. It's true the stockpile had run out, but that's because the Republican Congress refused the money to resupply the stockpile, to be clear. Next slide. Now we have the COVID plan. Many of you are probably not aware that we actually have a written document that is the US COVID plan. It came out on March 13th. In 103 pages of this plan, the term essential workers is never mentioned. And they only mention essential healthcare personnel once in the entire 103-page document. Next slide. And this may explain some of that. Although this is the structure of the coordination for COVID that they put into this written plan, you can see at the top of this plan who is in charge. The White House task force took charge of this plan. And even though this coordination looks like CDC has a big role, HHS has a major role, the truth is CDC has been badly sidelined from the beginning and all the way since. On the next slide, we come to essential workers. Now, in this photograph that was taken, they're saying thank you to gas station, grocery store, post office, delivery drivers, warehouse workers, farmers, all the food supply chain people, the meat packing people, utility, public works, law enforcement, and more. They said, and more, and that's so true. On the next slide, we can see that there are both traditional and non-traditional essential workers. Traditional essential workers are people that you are probably very familiar with, the first responders, all the frontline healthcare workers, which includes, for the most part, hospital workers, also all the mass critical infrastructure in the US, all those workers, communications, telecom, power stations, all those people are considered essential. Mainly the first responders and the healthcare workers are the ones that get special protections, training, and so forth. Non-traditional essential workers, however, they came to the fore during this COVID pandemic. They were the ones that were thrust into the role as a front healthcare kind of provider, yet they did not have any of the protections whatsoever in the beginning, and for many of them even now. For instance, they didn't have any kind of medical screening. They didn't have the proper PPE. They had no training. They didn't have fit testing for N95s. They certainly did not have supervision. And for the most part, they had no environmental controls whatsoever. And the impact has been severe. On the next slide. This is an interesting photograph I just came across. It's new. It's interesting in that these workers are now starting to coordinate. They are starting to come together to fight for their rights. And this is a sad statement in this photograph of these frontline healthcare and other essential workers out in Miami. And the article, they liken them to trick-or-treaters. They came down a line that was manned by this wonderful nonprofit group that was only giving away PPE. And they went down the line with their plastic bags open, and people down the line would throw in masks or whatever they needed. They were getting donations for the stuff that they needed. But the unions are coming together, they're coalescing, and they're fighting back, and they're suing the Trump administration. On the next slide. This is a memorial that went up at the MTA website, and it's showing some of the impact. We'll probably never know the full impact on how many essential workers in America died. A lot of that data is simply not being collated and collected. But here we know for New York City MTA, we had over 130 deaths, 90 of whom work for subway and buses. And these are just some of the people that have died in the last few months. Now, on the next slide, in the last few months, I would say really starting in March, I began a study of the Transit Workers Union employees, which represents subway and bus only. And that's a large group. It's about 30,000 people. And we did a pilot study. We anticipated a fairly small response. It was a web-based survey. We know from history that web-based surveys typically get 20, 30% if you're lucky. Within that first weekend, 500 people had poured into that website. Now, it was a convenient sample. There's no question about that. It's not a random sample at all. But it was a short questionnaire. We had several questions on whether or not they had COVID. Did they have COVID antigen? Did the COVID PCR positive? Did they have an antibody? Were their doctors ever told them that they had had COVID, or were they ever hospitalized with COVID? And out of that sample, 24% said yes to any one of those questions. Now, our sample is about 80 to 85% minority workers. Many of them are working very intensely with the frontline public, especially bus drivers, but many of the subway drivers as well. And in that survey, we also found that 90% of them were afraid of getting COVID at work, rightly so. And 70%, interestingly, 70% were afraid of being physically assaulted, abused, harassed, physically hurt at work. Now, that is a travesty beyond belief. Here are these people who came to work, made sure the other essential workers could come to work, made sure the city was running and the rest of us could be in lockdown or quarantine or isolation. They made sure the city was going. And here, at least in this particular group of transit workers, we have so many of them fearful for their own personal safety. One of the other important things we found out from this study is that about 35, close to 35% said they will never take the COVID vaccine. 30% said they would, and the rest are on the fence. I believe this is kind of mirroring what we're seeing in the general public. Probably Mike has those data more up to date, but it's going to be a problem if and when we actually do get an effective vaccine. Now, one of the recommendations we made in that pilot study was we said that the MTA should do some voluntary screening, because up to now they had to either find a place, maybe go to one of the sites that Jose was talking about, but they were not getting any kind of routine screening. And now the governor announced less than a week after we made our report that the MTA will now start the screening. So we cannot lose hope that the things that we do can lead to change. And on the next slide and final slide, I would just like to say it's critical that we bring science back into the management of all disasters, climatological, man-made, and certainly these pandemic or bio events, epidemics, outbreaks, and pandemics. We need people like public health. This next generation of public health students is critical to our ability to continue on as a nation and really as a world. And so it's imperative that we go out and vote and make sure we get the politicians in there who will believe in the science and believe in what the scientists have to say. And I'll end it here. Thank you, Joe.
Okay, thanks very much, Robin. And I think you opened the door to our final speaker, Professor Jack Caravanos, and when you talked about the transit system, which has been a huge preoccupation in the city and in many cities around the world. Jack is a clinical professor in environmental public health sciences at the school. He's also a certified industrial hygienist. So he's going to give us a sort of perspective on the complexity of really applying the interventions that we've been hearing so much about, and Mike mentioned it as others, the face mask, personal hygiene, social distancing, lockdown methods to various venues. And I think some of these are the venues where we're all very interested in: the issue of theaters, the issues of going shopping, schools, and dining and restaurants. And he's going to talk a little bit about how you look at those spaces and make them safer to complement the individual activity. So Jack, over to you.
Thank you very much, Joe. Thank you. Welcome, everybody. I'm the end of the line speaker, so I'll try to race through some of these. These are not pharmaceutical interventions. These are straight interventions. I wasn't sure what to call this talk, so I said maybe I should just explain what I've been doing lately. And it's a complicated world out there. We have all sorts of venues. Some are desirable, some aren't. Subways are so-so. We're not excited to ride on them, but we can't wait to get back into museums and restaurants and theater. And when you look at all the combinations, I started writing all these different venues and some of the ones that I sort of deal with. It's a wide array. And because you're in the biggest city, the best city, the most exciting city practically on the world, it's very frustrating. When can I go back into some of this? And we know all the usual interventions. Some of these will need face masks, some we social distance, some we totally avoid, like the subways. There are many people that just don't ride subways, period. So that's not social distancing, that's complete isolation. We also have a variety of hygiene and disinfection products. There's always another mousetrap that's being invented, and I'm being contacted saying, well, does this work? Can it work? Can it work here or there? So it is a crazy world. And of course, most recently now with the reopening of schools, people are becoming indoor air quality specialists and answering the question, what my windows don't open and where do I get fresh air and how many air changes per hour are necessary. So it's putting a big stress in our field with all these topics. And where do these boxes intermingle? At what point do we use all of these for one venue versus being at home, in which case you're not using any of them? So some of the observations in the past, we have foggers. People are putting disinfectants in foggers, hoping to release material and get a deposition. So you have sort of a long-term disinfection quality. It's not certain. One dilemma, I see, and I think most researchers realize, is we made so many changes. We intervened at so many levels. We essentially can never prove what worked. So do face masks work? Probably. Do we have any science that say face masks really did it? No. Because we did face masks, social distance, we did disinfection, we did ventilation, all at the same time. But I think it's pretty safe to say some are more likely than others to be successful. And here's something that I'm up against. We're doing some work with Uber and rideshare companies. This is a UV light in an Uber cab. And I asked the person, explain this. He goes, I don't know. I read on the internet and it seems like a good idea. And ultimately, he told me it makes people feel safer. So it's nothing to do with providing safety. It's really just sending the message. I am doing some work with the Broadway League where we're trying to figure out the best way to open up Broadway. Broadway is so complicated because you have the front of the house, you have the back of the house. Some of these are public spaces. Some of these are worker spaces. There are 16 unions in the typical Broadway theater, 16 distinct unions that all want to say in whether they can come back. But one of the most important things with Broadway is you need to be 100% full to make money. So there's no way you could social distance on Broadway. Every seat has to practically be filled for the show to continue. That's the reality of theater in New York. And here's one test that I was involved in last week. You see haze in the air, and this is a chemical that is hopefully will be approved by EPA to be an airborne disinfectant. This is a level that's maintained in the theater such that when you cough, the short distance between two people will give time for the virus to be inactivated with the glycol-based disinfectant. I can't tell you the name, but it's a glycol-based disinfectant, not unlike e-cigarette smoke. So we're hoping that this may help. But is this the only solution? And probably not, because you still would like to wear a mask and you would still like the hand hygiene, and you still, well, some of you would never even come in here because you're just not willing to take that risk. So it's a really complicated calculus. And that we see now with natural ventilation on the streets in New York. Some of these are great. I have no problem eating at these venues, plenty of air movement on an evening or during the day. But now we see some crazy structures. And if you're asking yourself, is that really COVID safe, that space? And the answer is probably not, because they're creating their own outdoor tight spaces in these bubbles. But the regulations are such that it's permissible, and we want some positive movement. We've also seen this report that didn't seem to get much traction, that the survivability of the virus in air, paper, metal products has been sort of studied early on, but people still just don't buy it. They still are worried about opening their mail and cleaning their food and handling plastics. So we do have this sort of crisis in trust and confidence, which of course is starting at all levels of government from the top on down. I do some work with building ventilation systems, and FYI, the 3 Fs, we want a lot of fresh air, we want a lot of air moving through a building, and we would like to also filter that air. This is very nice, it's very theoretical, but can that happen on Broadway? Can that happen in a school? Can that happen at a restaurant, retrofitting these systems? It's gonna be very tough. So what we have in risk is, I try to sort this out. There are things we want. There are things that we take chances, especially we take chances when there's something desirable, beneficial, maybe economically desirable too. And something like dining and theater and exercise. People want to go to Broadway and they're willing to take that as extra risk. So in one aspect, which of these venues is really amenable to that? Because some aren't, right? Subways. No one rides a subway because they like riding the subway. It's more like a reluctant risk. And of course, we have something in the middle, a voluntary risk. And this is a moving target for all of you. You all have different risk levels and risk tolerances. And the worst thing we could do is say one behavior, one intervention is uniformly applicable to everything. You know that life is not that simple. Compound these categories of risk tolerance with the fact that you have your pod, your immediate people you trust and know. And for me, it's my students every Thursday night because I know they've been tested. That's my pod. Then you have your family, your friends, and of course, strangers. So when you merge these variables into the different venues, it's a complicated calculus. And most people give up. They just say, I'm just going to wear a mask all the time. I'm going to obsessively hand hygiene. I'm going to avoid crowds, and I'm just going to lock down, which is the wrong way to go. You need to assess each of these risks individually. And I'm sort of proud of Cuomo in many ways, but it was very nice to see him out there sending a positive message, being in a subway, doing a show and tell with aerosolizing some disinfectant in the subway. Of course, he's not wearing his mask the right way, but that's okay. So this positive messaging has eluded us. We're getting so many different messages, possibly because of social media, possibly because of the election. There's so much politics between all these states. So it is a very frustrating thing to sort out all these interventions, especially when we don't know which is the absolute best. I do want to say that, and I believe Mike Merson also said this, that vaccines are part of the solution and not the single solution. We're all waiting for it. I can't wait for it, but it's not going to make everything better right away. And it's going to be part of the overall. I just also want to reinforce that when you are assessing a venue, to really ask yourself, what is your risk tolerance and what's the probability, and sort of go through this exercise in your head. Lastly, I said it before and other people have said it, leaders are providing a variety of conflicting, contradictory signals. Some people are discounting certain practices, not visiting cities, writing things off. And this craziness that we're seeing now, especially in this electoral climate, is very frustrating and interfering with good public health, science-based public health. So I think that's it for me. I'll take some questions, and thank you very much, Joe.
Okay, thanks, Jack, very much. Thanks to everybody. Really, the questions are pouring in. I'm trying to, I think that just for those of you that may not be that familiar with the US healthcare system or federalism, I think we're not going to solve that problem on this seminar. So I'm going to stay away from, there are several questions there, which are really important questions, as you've heard from a number of the speakers. But let me start out with a technical one, for some short answers, maybe from you. And then I want to combine some issues around communication and risk tolerance and trust that we've talked about as it affects different systems. So there's about 2 or 3 questions really talking about which kind of screening really works. I mean, people are saying, if everybody's screened by in what method before they come into a space or a classroom or school or whatever, what do we know about the different screening methods and, obviously their effectiveness, but also practicality. And then similarly, the sort of general policy approach to screening, maybe this is for you, Mike, the difference between starting from the individual who's been identified as infected and tracking their contacts versus looking at clusters. And someone points out that that's been more of an approach in some of the more successful countries, looking at outbreak clusters, which I think we're starting to do, and going into that cluster area as a basis for tracking. So let me ask the general question about finding the screening process from a population point of view. Mike, maybe let you start that, and then maybe Jack or others want to comment, Jose, from your experience, or Robin also. Just what's your sense of effective screening at this point in the epidemic, knowing that science is evolving?
Challenging questions. First, on the testing, the PCR has been our standard test so far.
Spell out what the PCR is.
Sorry. Well, it picks up a piece of the virus.
Okay.
And the problem is that it's expensive, it takes time, it needs a central lab of some kind, and it can have false positives, and this has, as well as false negatives, but in particularly, it picks up people before infection, during infection, and after infection. And as a screening tool, it's not practical in many settings. And so the feeling today is we mentioned in my presentation, we need more sensitive and specific rapid tests, which can be done. They are going to be more likely positive when someone is infectious, not often positive in the pre-infectious as PCR, and certainly in the post-infectious period. But they are very good for screening because they are most likely positive when someone is infectious. So there is now in many universities in particular, but elsewhere, having 2 or 3 rapid tests in a row is seen as better than having a PCR test. This is where we're headed, particularly as the rapid, and these are, when I say rapid, I should have said rapid antigen tests. And they are a different platform, and I think will eventually become the main test that we use, with PCR as a confirmatory test. That, I mean, others may feel differently, but I think that's where we're headed. I would personally rather screen people with 2 or 3 rapid tests and get a result in 20 to 30 minutes than a PCR, which is going to take me 24 or 48 hours, if I'm lucky, to get a result back. On the issue of testing and tracing, contact tracing, that is effective mostly when you're at the beginning, when you have, before you reach a massive outbreak, when you at the beginning of an outbreak in a situation, trying to quickly identify contacts and testing them can be very effective. If during a period where we had in New York way early on in March and April, we long passed the ability for testing and contact tracing to solve anything. We had a massive epidemic on our hands, and we're way above what that could do for us. So it's very effective if used early, and that is what we have seen in the Asian context: aggressive testing and contact tracing. The cluster approach, which is particularly used in Japan, I think that is based very much on the recognition that much of our spread of COVID occurs in large settings. We talk about often by super spreaders, and I think that is a very valid approach that we should be doing more of. But I think it's been very revealing that the 2 places where transmission occurs most often is in the household and in large gatherings. And I think the cluster approach for finding those large gatherings can be very effective, as we've seen in Japan. That's a quick answer to those questions, Joe.
Thanks very much. Jose, let me ask you, just in terms of the debate or thinking that went on as you kind of launched the screening and testing, and now has it changed as you've watched it? How is Health and Hospitals approaching that at this point? And what are the constraints about maybe doing the version you'd like to do? There may be financial constraints, or maybe availability constraints.
Yeah, I mean, being that debate was complicated, as you know, and I think part of the decision, the way that it played out, was connected to the fact that H&H is a large organization and could hire quickly to make this work, and because many of the services were also integrated with the healthcare delivery side, it made some sense to do some of those activities in the hospital system. I mean, I think one thing that because I was looking at data, the data that they put out on the testing and tracing program, on how successful or unsuccessful the program has been, and you can see how at the beginning, the number of cases reached. I'm looking at a graph here. It was about 80% at the beginning of June, and then they had a goal of 90% plus, and over time those numbers were reached. So I think although people have been very harsh in terms of like, does it work? Does whether it works or not. I mean, in terms of reaching the goals that they set, they have been able to do that. Um, I haven't seen anything connected to how effective that has been to control. I mean, linking it like, okay, this is what we're doing. This is why our numbers are much lower than other cities or states in the country. Um, it, I know that it has been a learning process, and it was very chaotic and complicated at the beginning.
Okay. I know Robin, you and Jack both leaned forward. So Robin, you want to comment on this issue relative to the screening, testing, that you experience? I mean, just the technical aspects of it, I think, the reality testing of it.
Yeah, I think the rapid test is going to be the gold standard very soon. I think that can have so much utility. Won't be practical, obviously, for some place like a subway, but it might conceivably be possible, and Jack can speak to this, to maybe theaters. If all the theater goers go to the theater, say an hour before showtime, get on a line, have several people there to do the rapid test. I believe some of those rapid tests are as quick as 15 minutes, if I'm not mistaken, and they'll probably get better, and they'll get better and quicker. So it could have utility certainly for schools, maybe shops, maybe someplace. It's hard to picture for Macy's. I do want to backtrack to something that Jack said, and that was about, doing all these things for show. At one point, the subways were installing these UV lights. And by the way, that one in that Uber, it looked like the light could have hit the passenger's eyes. And that's, of course, really risky. But it was kind of crazy. And of course, the subways are spotless, and you probably could almost eat a meal off the floor. But a lot of that is the illusion of safety and security. And that's not for nothing. That can go a long way into getting people to feel comfortable in a setting. But we're beyond the point of illusion. Now we need the real thing.
Yeah. Jack?
Yeah, let me comment. Thank you, Robin. I was very hopeful with the Abbott 15-minute test. And it's not CLIA certified, so you need a medical professional to administer it. And that's the obstacle there. But I think it does offer some immediate sense. I mean, I've been tested 6 times now this semester, and all I know is the day after I've been tested, I could still be infected. So that 15-minute test, I would love it, and I think it will really help, especially if we can get it something as simple as a diabetes prick or a pregnancy, color change.
Yeah.
Let me segue into another sort of try to group a set of questions. You've all touched on it one way or another. I mean, one of the issues, both in the healthcare delivery system, in terms of we're looking at vaccine distribution, testing, screening. What's going to make people trust the system, cooperate, engage? And you've touched on issues of communication problems. We've had terrible mixed messaging in this country that's confusing people. And then that leads to a trust issue or a risk aversion issue. I like your categories of risk, Jack. And then also the issue of historical suspicions, especially in communities of color. Jose talked about maybe Health in Hospitals has a higher trust level because it's historically been providing services to those communities. But Robin, you talked also about a workforce that is largely from the communities that have historically not been that willing, if you will, or that feeling that they were being reached out to in a positive way, other than here they come again in an emergency. So maybe we could talk about that trust factor, that sort of feeling safety for risk factor, just from your particular perspectives, not philosophically, but just as you've seen those issues play out in the projects and the work that you're doing.
I think it would have helped enormously if they hadn't called it Operation Warp Speed. That connoted that we're going by the seat of our pants as fast as we can. That's not the way to instill confidence in the population. The H1N1 vaccine was developed by CDC. It was a very successful vaccine. It was a good vaccine. And as I said, it came out very early. This seems like it's this company and that company, and they're pausing, they have to pause. Now I saw today they're waiting for 36 cases for one vaccine. It feels so scattered. I think it would have been better as a national strategy. From my perspective, I think that would have been better.
Yeah. Jose, do you want to jump in here relative
Yeah,
to your system and on the front lines?
more than anything, I mean, I think that at every level, it's hard work to find trusted voices. And if anybody wants, what people want is to see those trusted voices saying, you know, this is a good thing to do. Taking a vaccine is a good thing to do. Following certain behavior is a good thing to do. I mean, it reminded me of a person that I know well, whose father actually died from COVID. She's a leader in a healthcare system, African American, and she's been a voice on TV, basically talking about the fact that she wants to be part of the solution on this. And I think that it's not just simply anybody at the federal level. Having to do the work of finding those voices is something that needs to happen for people to trust the system.
Yeah, really good point. And hopefully public health professionals increasingly will be sources of that information. I think that's a really important point. Jack, let me ask you and then go to Mike on this one. You're talking about the area of assuming risk for things that you may or may not wish to do, but you need to do, and this trust factor and communications factor as you saw it play out.
Yeah, it's. I feel like not many people are doing a risk assessment. Meanwhile, we do it all the time. We decide, should we cross the street an hour later, wait for this, go here or there. So we're constantly processing information, judging harm, judging enjoyment and pleasure, and making these decisions. I think the fear, and as Robin will tell you, that risk perception is often a balance between known and unknown. So this is an unknown hazard, just like Zika and Ebola. We were very afraid of these agents, combined with an involuntary aspect that we're not choosing to be exposed. So between those two factors, people are really giving up and just sort of locking down.
Yeah.
But
when you're working with people like from the theater industry or the school, the officials that have to perhaps take on, I've heard of a lot of business discussions, the extra expense of making certain changes, in the physical arrangements, dealing with potential anti-disinfectant, et cetera. How are they responding to this issue? How are they thinking about this question?
Yeah, big companies in office buildings are really investing a lot. They're spending a lot of money cleaning and disinfecting offices that have been closed for months. Meanwhile, there's probably no virus anywhere near the office, but of course they need to do this to convince their employees to come back and make every effort. So a lot of my friends and colleagues are very busy certifying that areas are clean and ready to be reopened. Whether it's almost, you want to create a sense that this is brand new and we've just painted and ready to move in. And I think that's part of reopening New York, especially the office buildings, Wall Street and businesses.
Yeah, and people getting back and forth to work. It's like connecting the work that you two are doing, I think, really important.
Robin made a great point. The subway is cleaner than ever. I ride it every few days and I get a seat. I don't touch anything.
People are very well behaved. I've been riding it a little
I
bit.
know, it's crazy. So now's the time to ride.
Yeah. Mike, just drawing on, I wanted to ask you specifically back to your notions of the countries or the places that have been doing it right. Could you connect that to this issue of communication and trust and in institutions or risk-taking, et cetera? I mean, these are cultural questions deeply, but still, maybe just from your experience.
And I think there's no doubt that particularly in Asian countries, there is a lot of trust in government and in the leadership. I think 100% of Singaporeans where I work will take a vaccine if their the head of their ministry or the head of the government tells them to do it. I think in this country, and I've seen this also in Latin America and some parts of Europe, the individual street that we have in our culture flamed now by social media really does present a challenge. Look at the problems we've had with vaccines, irrespective of COVID, in New York City. You know better than I, with measles, and look at the problems we had in HIV early on. So I think one of the difficulties is that those that we in public health don't get trained in this area. We're not very smart in communications and understand. I mean, we can communicate maybe to each other and present papers, but we don't do very well in thinking and knowing how to communicate to the public. And so I think what's most important, and I think Robin got to this, is finding local communicators who the public will respect. And I think that has happened a lot in Asia as well, with NGOs, non-governmental organizations, bringing them in, and also bringing in communication experts who have sold other products to people. I think using the private sector, if that's permitted. I do feel that we need to call for help in this area, and we need to think locally. I know Jose's point is well taken. Sometimes it's not easy to find the best local person, but I think we really don't have a choice right now. We are not going to be able to turn around easily the politicalization that exists in this country right now, even after the election. We're not going to be able to turn a switch, I'm afraid.
Yeah, that touches on another question that several people were interested in. Really is so what would you recommend for the U.S. going forward? I mean, we've got this combination of a federal structure, very decentralized, sort of a president and a political party that historically has valued independence, has valued decentralization, has valued states' rights. We see the results, which we have different feelings about, but it's not, that's not new to COVID. It's not, it's probably the fact that it hasn't been addressed in the face of COVID is the issue here. But, and I think it applies to the issue of structural racism and other issues that we're trying to address kind of as a country, and the lack of a, we don't have much that pulls us together, like a national health service or universal financial coverage or other things. From your own, I mean, this is partially philosophical, but partially just from experience, what have you seen that works in terms of getting people to take up common cause and kind of, engage in trying to find win-win solutions, I guess, to these public, and how can public health be active in that role, perhaps is the better question, because it's not deeply embedded in our culture. Certainly it is in others. Mike, you want to start off?
Yeah, well, of course, a lot depends on what happens in next week, but I think we've got to step back now, and I don't want to say one party or the other here, but whatever happens, we've got to make an effort to bring us together as a nation. And I hate to say this, but since so much more of the country will have gone through what New York went through and California went through, maybe that experience will open the door for a rapprochement of some kind, initially politically, with the help of the private sector, with the help of church leaders. I think we need an all of government, an all of nation hard look at how we're going to come together, particularly, as I say, not just because more areas going to be infected, but all the numbers look quite frightening in terms of the number of beds. We're seeing already hospitals going through in the north central part of the country what we went through in New York, rationing beds. So there's maybe a silver lining in that, but I see no harm in trying. I think we've got to try. Whoever wins, whatever party wins, and if we don't come together, as we've said, I don't think this is going to be solved by a magic bullet.
Yeah.
Oh, and Joe, I'd like to just point out that, as we all know, pandemics do not know state borders. They do not know country borders. Now, after 9/11, it's very curious. The country pulled together enormously after 9/11. It didn't last very long, but there was that sense of we're in this together. Somebody tried to hurt us, and we've got to be cohesive and fight this back. But now with the way CDC's been, I do believe in CDC. I think CDC has to be the arm that will help to mount a national response. They can come back. They hemorrhaged incredible people at the beginning of the last term, and they're still out there, these wonderful people, past directors, the brains behind all these epidemics and pandemics. They're there. And I know that they will take the call on and come together to help us get through this. Because look, one number I just saw that scared me. They said that economists like Larry Summers said, this pandemic will cost us $19 trillion or $125,000 per household. If we don't get our hands around this right now and any other future bio-event, and believe me, there are many, many still to come,
Yep.
we will not have a country to be fighting over.
Yeah. And I mean, we're not going to be able to have time to go into this, but I know other countries, especially European countries, have had a very different approach to economic supports, and social supports during this system that we have not used. And that's something to look at and be aware of. Jose, coming into New York, I mean, one of the real challenges in the hospital systems in New York is the competition, the way these systems are put in competition with one another. And as the public system, which, as you say, cares for people regardless of ability to pay. How have you seen the systems coming together? Do you see it as something that's sustainable in terms of longer term, better integration of healthcare systems in New York, at least?
I mean, there's some of that goes on because this is something that impacts everyone, and all the systems are trying to deal with overcrowded emergency departments and what happens when the revenue sources go down because nobody wants to go to a hospital and so on. The hard part is the financing side of things, and the way we are the model that we have where money may come from the federal government. Let's use it a certain way, and then politics get on the way on how is that money distributed across systems and so on. And we don't have a clear system in this country where the resources go to the person that needs it the most.
Yeah.
And there are like too many cooks that have vested interests on that.
Yeah. Well, we'll see. Again, I think this election becomes important for the vestiges of the Accountable Care Act and what might be changed.
I wanted to say though that you mentioned something about the role of public health, and I think public health schools, because we are very interdisciplinary and we have a population health model. We think a lot about disparities. The way it's almost like COVID-19 was built for us in some ways,
Yeah.
Because we have that expertise, and it's a matter of how do you take that knowledge at the different schools and sort of like deploy it.
Yeah, important. Jack, just quick word on the cohesiveness question, I guess, in terms of making change. And then I'm going to come back. We talked about this before the seminar. We want to have each of our speakers address the issue that Jose started to talk about, but directed specifically at public health students. How do you see the contribution they can make, and what makes you excited about being in a school of public health, and how would you encourage students to move forward? But before we do that, Jack, just quickly on any comments you might have about what to do in the U.S. to sort of address some of the issues you raised in your presentation.
Well, yeah, as with so many problems, there's many levels of interaction, and too often we always look for the magic pill, the magic vitamin, the magic action. In this case, it's going to be a combination. Clearly, vaccination is going to be very high up. Also, quick testing, I think, is going to be very high, where within minutes, someone can be certified, okay, you're clean, you can go in. I think those are probably going to be the two big ones. But we do have a lifetime change. You will see people, I've been to China, they wear masks, seems like everybody all the time. And I think America will be like that. New York will definitely change. We don't have to, I shouldn't say we don't have to worry about the Me Too movement, because now the whole thought of touching anybody is taking a whole different level. So we have a lot of good things, and this will positively impact all infectious diseases once we get sort of these behaviors institutionalized.
Yeah, I think we're seeing flu rates go down in others, probably because of the steps people are taking. So on to our final question, just to wrap up. For those in the audience, and we don't know how many there are of you, but I'm just looking at names and the kinds of questions you're asking, probably a lot. People who have are in their studies, let's say, either just begun or in their studies for public health, what career advice would you have for them during this time of pandemic or beyond this in terms of shaping career and career experience? Robin, you want to start?
Well, of course, I'm very biased because I teach 3 different disaster courses and now we have a disaster certificate. But this is something that's very curious and it kind of touches on what Jack said. And this is the fact that every place now needs an emergency manager. Every place. All of a sudden, grocery stores need an emergency manager, theaters. There are jobs opening up that were never even, they didn't exist prior to this pandemic. And I do agree, I think things are going to change. I cannot imagine people will go on subways with face masks in the wintertime where 90% of the car are coughing, sneezing, sniffling. That's not going to happen anymore. People will be wearing masks. But just like they'll be wearing masks, every large business place, every kind of venue where people are coming in, lots of public, I think that they are going to need emergency, at least somewhat trained emergency personnel. And so I think it behooves public health students to know that topic, at least a glancing familiarity, as well as risk communication. We are desperately in need of more risk communication courses. And when they come, and I'm sure they will, that's what students should be taking.
Yeah, great points. Quickly, now I'm getting the red light from the manager of this seminar. So Jack, quickly, and then we'll end up with Mike. We'll go to Jose and then end up with Mike,
Okay.
Starting and ending. And then I have a couple remarks at the end.
Yeah,
Go
no,
ahead,
I think Robin said a lot. I just want to add to her comments that you have an you meaning students, have an obligation to really be the leaders, the champions in this. Not just because you're at NYU, but when you say I'm a public health major, people are gonna all of a sudden the ears are gonna pop up, and you got to be ready. Come to me, come to your professors, come to Mike and Robin, and there's so many, and Danny Umpog. There's many capable people that will help you get the answers. But you are our ambassadors, and we expect that of you.
Jose?
Yeah,
Jose's a great hybrid because you're like a public health person and a healthcare person. So you bring these guys together.
2 things came to mind. So besides all the great advice that has been given, one is focus on get the health disparities angle and equity issues, get into that, because every health system is struggling with this. Every business is struggling with this, and many of the issues that we're having to address have a disproportionate impact in certain populations. So if you're studying public health management, for example, systems want people that understand that. The second one that I'll say is entrepreneurship and business opportunities. The whole system is being disrupted. There are going to be tons of opportunities to do everything from technology and contact tracing. Some students have been working with me on that, to many other things. So don't shy away from that.
Okay, quick comment, Mike. 1 minute or less.
I would just add, Joe, that it's a great time to be in public health, global health. I would say to every student, take a few minutes and write down what you feel now so you remember what it's been like during this period, and go back and read it later on and allow it to help you figure out what your passion is going to be and where you're going to make a difference, where you want to make a difference. Because I think there are many paths, as you've heard, that you can follow.
Okay, thanks. And I want to emphasize just a last comment. I think there's a really honorable history of activism, both in medicine and in public health. And my favorite quote is from a German public health hero, Rudolf Virchow, in the early part of the 19th century, who said, "Social inequality is the cause of diseases that require political action." So we've been hearing that during the last hour and a half. And one of the things that this school and New York University in general have been pushing very hard, and you've heard it already today, is let's have political activism by voting. And everyone, please plan to vote between now and or on Election Day next week. So we thank you very much for joining us. Thanks to the panel for absolutely fantastic participation. And we may save the Q&A and shoot them to you because people are asking for answers to their questions. So you may have homework after this. Thanks so much.
Thank you.
Bye-bye
Thank
now.
you, everybody.
Bye.
Very much.
Bye.
Bye-bye.